Good morning. Welcome to the critical appraisal series short course in epidemiology, which we have been conducting every week. And apologies, we are starting a bit delayed because of a concurrent conflicting academic schedule in our program. So apologies for the same. Meanwhile, thank you all for the online participants for having joined online. Today we will be discussing on crossover trials. We have discussed multiple other study designs. And recently we had a systematic review workshop as well, which we had organized on behalf of Cochrane India. So we thought we will just go through risk of bias 2, which is the new risk of bias tool, assessing tool, which is present, which Cochrane recommends in place of risk of bias, the usual previous risk of bias tool. So there has been a modification for crossover trials as well. So we have Dr. ANUKA who will be making that presentation. And she has chosen an article from Annals of Internal Medicine, which is a crossover trial. And she'll be doing a risk of bias assessment using this new tool. At the end of it, we'll also show you where we can see if we access this tool and how you can use this interactive Excel tool as well. So please feel free to post your questions in the chat box, or at the end of the presentation, you can unmute yourself and ask your questions. And without any further delay, I'll hand over to Dr. ANUKA. Thank you, ANUKA.
Good morning. My name is ANUKA. I will be doing the critical appraisal of a randomized crossover trial using the RoB2 tool. So, brief discussion on what is a randomized crossover trials. So, this is a simple design of a randomized crossover trial. This is a APPRAISER sequence with a 2-period study. So this is simple APPRAISER sequence. So this is a simple crossover trial. There can be a complicated trial which consists of multiple sequence and multiple phases. So what is the advantage of doing a crossover trial? So crossover trial has few extra advantages, that is, it permits a within-person comparison. So the confounding in that terms are taken off. The participants serve as their own control. And because of this, less study participants can be used to do the study. And one other advantage is we can make a preference for each individual participant for both the interventions. What are the challenges? Some of the challenges are it should be a suitable chronic condition. So it cannot be done in an acute condition or something like a cyclic disorder, because in both the periods the condition will change. The treatment effect which is studied has to be reversible and temporary. If there is something like a permanent, like a death or a pregnancy in a fertility trial, it cannot be used because it is the other period. Something about carryover and period effect we will be discussing as we appraise it out. Coming to the case scenario, so a lot of interns have come from chat. So there's a 65-year-old farmer who is being referred for a high blood pressure value from an out clinic in chat. The documented blood pressure is 150/70. He is subsequently seen in the private medicine OPD, and there his blood pressure is documented by 140/70. So we wonder which blood pressure value can we rely on. Is there an effect in outdoor versus indoor and with the public or the private? I will be appraising this trial, which looks at the effect of noise and public setting on blood pressure reading. For that reason, I will be using the device Cochrane risk of bias 2 for crossover randomized trials. The background is guideline emphasizes quiet setting for blood pressure measurement. Quick review of the guideline. This is from the American Heart Association guideline. This is a summary. We look at the things which are highlighted. Proper preparation. So patient should be sitting relaxed on the chair, feet on the floor, back supported for more than 5 minutes. Should avoid caffeine, exercise, smoking for at least 30 minutes. The patient or observer should not stop during the period or during the measurement. Proper technique has to be used. The arms have to be supported while taking the measurement. The other usual things, correct cuffs, correct position. Both oscillatory and palpation methods should be used, and they should not talk during the rest period during the measurement. The other thing is advantage for a diagnosis. You should use an average of more than 2 readings, which is done on more than 2 occasions to estimate the levels of individual's BP. So outline of today's talk would be internal validity using the RoB2 tool, results and external validity using the CAD checklist. So this is something about the RoB2 tool. It provides a framework for considering the risk of bias. There are 5 domains which are looked at it. The bias arising from the randomization, bias due to deviation from intended intervention, due to missing outcome data, measurement of the outcome, and bias in selection of the reported result. So there are multiple signaling questions in each domain, and the possible answers are yes, if there's a firm evidence, probably yes, which is a judgment call, probably no, no, or no information. The end of this assessment after the domain, the final, we can conclude it either is a low risk of bias, some concerns, or high risk of bias. So we will be using this tool for this study. This tool, if you go to the website, this is how it looks, and I've used the RoB2 for crossover trials. It has a full guidance document. It has an Excel tool in which the data can be inputted. This is how the Excel tool looks, and you can use the assessment form to input the data. This is how data is to be inputted. So going to the study, effect of noise and public setting on blood pressure readings. So this is an individually randomized crossover trial registered in the clinical trial registry, funding by Resolve to Save Lives, but which had no role in the design or publication of the study. The hypothesis was BP measured in a loud public space would be higher. Coming to the PICOT statement, the population were community dwelling adults from Baltimore, Maryland. Interventions, there were 3 settings where triplicate BP measurement was taken. The first was private quiet, which was a private quiet office. Second was public loud, which was a noisy public place. Third was public quiet, noisy public place with a earplug. The primary outcome was difference between the BP obtained in public setting, each of the public setting versus the private setting. There were multiple subgroup analysis planned, which was blood pressure compared in relation to clinically relevant subtypes, hypertension, age, or health utilization. So it was a single visit study, time period about 2 hours, and setting was in Baltimore, Maryland. Inclusion criteria, all adults aged 18 or older. Exclusion criteria, anything that would have prevent measurement of BP, so presence of rash, dressings, edema, paralysis, wounds in that area. Pregnancy, medical impairment precluding participation in the study protocol. Arm circumference, which was more than the BP measurement they used. Hearing loss requiring the use of hearing aids, which would impair them using the earphones. Inability to walk across a busy urban street. This was pretty relevant exclusion criteria which was chosen. How did they get the patients? The population screen were one from the public food market near the Johns Hopkins University School of Medicine. So these were both patients who were diagnosed and undiagnosed hypertensive. Direct mailing to previous participants requested in some other study. Placement of information brochures in hypertensive clinics, and referrals from patients, from doctors who provide hypertensive care to patients. So coming to the 3 sequence, so they had 3 sequences. One was public loud. So this was indoors in the Northeast market in Baltimore's public market. Public quiet, which is the same place with the disposable earplugs, which was certified by the American National Standards of Institute. It reduces the noise rating to 32 decibel. So the noise in all the areas were recorded by a decibel meter, which measured the decibel in each of the 3 settings. And third was a private quiet. This was a non-clinical office facility in the university. It was located 180 feet across the street from the market. So they walked in these 3 areas, and all of them underwent the 4th measurement in a private quiet, which was just to see inter-person variability. So there were 2 measurements in the private quiet. So just for reference, a normal conversation is 60 to 70 decibel. City traffic approximately is 80 to 90 decibel. These are some pictures to show. This is the Northeast market, the aerial view. This is something I found from the Yelp review, and this is probably a Facebook picture. So this was one of the public market. We will go to the using the tool. So there are 5 domains. The first domain is bias arising from randomization process. Was the allocation sequence random? So because there are 3 settings, they had 6 possible combinations. In each setting, they had 3 sets of triplicate BP measurement. And all of them underwent in the 4th setting, which was a private void 2. So out of the sequence random, they have not mentioned anywhere in the study or in the study protocol. But because it's published in this, I have given as a probable yes, because even if the allocation is not concealed, there is it may not make much effect to the way the sequence they have taken BP, because in the same day they have taken in all 3 settings. Was the sequence concealed? There's no information about that when it this scope. Is there a baseline difference between the intervention group at the start of the first period that suggests a problem with randomization? So this was the baseline characteristics. So you can see there are 6 groups. They had total 108 participants, and it's been unequally distributed among all the 4 groups. Few things to highlight: unequal distribution, and there was a group 5 which had the least number but had 0 people with previous history of hypertension or heart attack. Other thing which was some discrepancy which didn't make sense was the Black race and non-Hispanic ethnicity. That only total 108 participants, but I think there's some mistake in the way they have given 10791. But that is across all the thing only in this domains. But they have used non-Hispanic ethnicity and blacks. So the final score, concealed, probably yes, random, no information, comes to balance suggests a problem, yes, to show some concern in this domain. Second domain, domain arising from period and carryover effects. So what is period effect? The period effect is difference in the response in the second period compared to the response in the first period. For example, even if the participants are given identical intervention, the values in the other period is either more or less. An example, suppose this is randomized into A and B, and other is B and A. There are 2 periods, and if we assume these are exactly equal, identical intervention, but your effect in the A period 1 compared to period B, suppose the period B is lesser, then when you measure, this will be biased against A in the period B, and it will show biased against B in period A. So that is problem with the period, but your treatment is identical. This is called period effect. The way to circumvent this is you should have an allocation of 1:1. Even if the allocation is not equal, there can be some statistical analysis that can be done to circumvent a period effect. So coming to our study, was the number of participants allocated to each group equal or nearly equal? No, we saw that they were quite unequal. So they had 6 groups. The numbers are different: 21, 18, 14, 28, 11, and 16. So this was not equal. But where period effect accounted for in the analysis, so they have actually done sensitive analysis just to account for the period effect. So treatment order, and they have included the random effect in the model. So they have done analysis to circumvent the period effect. Now second is the carryover effects. So carryover effect is a situation in which the treatment which is given is carried over from the first period to the second period. So it interferes with the second intervention. Now, similar example, randomized into 2 groups, 2 periods. Suppose first is active intervention, second is a placebo. So you expect positive outcome with the active intervention, but placebo is an inert substance. But suppose if this intervention action persists in the second period, the placebo also will show some effect. So the overall effect of this will come down. But in this arm, placebo is inert, will not show effect, but this will show effect. So this bias is the carryover effect, the effect of one going to the other side. How to circumvent that is to use a washout period. So you finish the first period, then you give a sufficient washout period that the effect of the intervention in the first is over, and they achieve something called a steady state. Coming to our study, so was there sufficient time for carryover effect to have disappeared? So here intervention was blood pressure measurement. It was not a treatment as such, so there is no carryover effect which is expected. So based on this algorithm, there's low risk in this domain. Now coming to the next domain, that is bias due to deviation from the intended intervention. Were the participant aware of the assigned intervention during each period of the trial? So this was an open label trial. There was no blinding. So the participants were aware, and the people delivering the intervention were aware of where they were assigned. Were there deviations from the intended intervention that arose because of the trial context? So we'll just look at what was the sequence. So they had 6 possible sequence, 3 settings. A staff member accompanied the participant during the transition between the 2 locations. All BP certified staff. For consistency, they use almost right arm unless there was some specific reason. Then all measurements were using a validated oscillometric BP device. And initially they all written consent was obtained in the private office, from where they went to the different setting. The participant's arm circumference was measured to make sure the BP size is correct for this measurement. There were 4 sets of BP measurements taken, and the sequence was they'll walk for 20 minutes, reach to the setting, 5 minutes of rest in the seated position with the back and feet at rest, and an automatic BP recording. It will record 3 BPs taken 30 seconds apart. And they were asked not to talk or use smartphones during the BP measurements. An average of the readings were used for analysis. So till now, this was what we planned in the protocol, and the same thing was done. There's nothing extra done out of context. Was appropriate analysis used to estimate the effect of assignment to intervention? Yes, they have done an intention to treat analysis, and there were no missing records. So they have taken all the accounted, all the values were accounted for in analysis. For effect of adhering to intervention, so were participants aware of the assigned intervention? It was an open label trial. Yes. Were carers and patient people delivering the intervention aware of participants' assigned intervention during each period? Yes, they were aware of that. Were important non-protocol interventions balanced between interventions? So there was no other non-protocol. This is if they are getting some treatment, some other treatment. This was not applicable in this study. Was there non-adherence to the assigned intervention regimen that could have affected the participant outcome? No, they had fully adhered to the protocol. Was the appropriate analysis used to estimate the effect? Yes, they have done an intention to treat analysis. So coming to this algorithm, for both it shows low risk. Overall risk of bias in this domain is a low risk. Second is bias due to missing outcome data. So there's some data which are not available. So here, their measurement was BP records, and all the patients had BP records, nothing was missing. So based on this algorithm, this domain also shows a low risk. Next is risk of bias in measurement of the outcome. Was the method of measuring the outcome inappropriate? No. So all the blood pressure readings they have taken was from a standardized setting. Could measurement or assessment of the outcome have differed between interventions? No, they are all using the same validated measurement. Were outcome assessor aware of the intervention? Yes. Could assessment of the outcome be influenced by the knowledge of intervention received? Actually, no, because outcome was blood pressure variation and the measurement was BP recording. So based on this algorithm also, it's a low risk in this domain. Now, last is risk of bias in selection of the reported result. So this is different from missing data. Missing data we have covered. This is selection of the reported result. One example for that. So the 3 terminology: outcome domain, outcome analysis, and outcome measurement. I'll just give you an example. So outcome domain, that is the endpoint of interest. For example, if suppose we're looking at something called a severity of depression. So analysis would be the scoring, like Hamilton scoring for depression. Measurement would be the change in scoring. So if you look at this study, suppose the trial measurement is looking at depression and anxiety. They have taken Hamilton and modified Hamilton and scoring for anxiety. In the trial, they have looked at the change of values, but the result is showing significant report for depression, but anxiety is not showing any, suppose not showing any positive outcome. If only the depression values are reported, then suppose this study is used for a meta-analysis of anxiety, then there is a high risk of outcome of non-reporting bias. So this is a bias if there is a selected reporting. We look at our study where the data that produced the result analyzed in accordance with a pre-specified plan that was finalized before the unblinded outcome data were available for analysis. So here is the study protocol which was done before the study, and this is a clinical registry trial. Based on this, there is no obvious change in the analysis plan. So what was done was exactly what was done. Is the result being assessed likely to have selected on the basis of results from multiple eligible outcome measurement? So here there is a single outcome measurement for this outcome domain. Is a numerical result being assessed likely to have been selected on the basis of result from multiple analysis, eligible analysis? So there's no evidence that selective reporting has been done, and they have presented the unadjusted analysis in the final result. Is a result based on the data from both periods sought, but unavailable on the basis of carryover being identified. So here both the data are there, and we have established that there is no carryover. So based on that, this domain also shows a low risk. So this is, we had seen how to input in that assessment form. So if we input the whatever we have discussed with the assessment judgment low, it comes as low for all. But in that first, because the allocation was not concerned, if you put assessment judgment as some concern, it comes as some concern. So this was not covered. This is a sample size calculation. So based on 80% power and type 1 probability of 0.05, the sample size for them for a clinical meaningful difference they looked at was 2.5 millimeters of change. The sample size was 100. So they had achieved 108. So they had achieved the sample size. Now the second two part, results and the external validity, I'll be using the CAS questionnaire. So this was a result. So this was the three settings they had planned, public versus private, and this was private 1, private 2. This was to look at interpersonal variability, that is similar, but it's also similar to the public loud and public quiet. So actually there is no much difference in both systolic and diastolic BP. The same in a pictorial representation, and the same in the sub-analysis when it's adjusted for BMI and arm circumference. So this is the RT test analysis. If you look at it, it's a wide confidence interval and it's not a significant, statistically significant outcome. So BP measurement for them in the both in the private and the public was similar.
Just stop for 1 second there for the people to understand. Normally, when you do RCT, we have two arms. And you have a continuous outcome, blood pressure. We do a t-test. Because we're looking at the different student t-test, what people say. So the blood pressure between the two arms may be different by 5 millimeters. The difference we are assessing that can be statistically significant by doing t-test. But the difference in a crossover trial is each patient at one point was a patient, one point was a control. So you can't just do a simple t-test, you have to do what's called paired t-test, because each person is being, each person's prior value affects his next value. That's very important in critically appraising a crossover trial to see whether they did the statistics analysis correct. Some people just look at like a normal RCT and do simple t-test. That is wrong. Some people will just do the first period before crossover and analyze the results only before the crossover. That's also okay. It's a parallel arm trial before that. But since you did the crossover and you're looking at the end, what they have done is correct, the paired treatment. So just to keep in mind, somebody did a crossover trial, they should have done paired treatment. Second thing, suppose you're doing a systematic review. You have many parallel studies, 3 studies like this, but without crossover, and 1 crossover trial. You can't simply take the data from the crossover trial and put it into the systematic review to do some adjustment. In systematic review, if you find 1 crossover trial, when you deal with that, that's called unit of analysis issue. Because this is not a simple RCT. Each patient has one time was intervention, after some time he became controlled. So systematic reviews, people call that as unit of analysis issue. It's not common, but all of you, I hope one day will start doing systematic reviews. If you find one of the RCT has got a crossover, then first you must see whether they did the correct analysis. Second question you must ask, when I put this data into the overall systematic review, how did I deal with that?
Same, this is a subgroup analysis in a forest plot. So each of the subgroup they had planned, there's no significant difference. So coming to the last part, will the results help locally? So are the participants similar? So this was a single center trial in Vellore, but had a white and black ethnicity. We know that ethnicity has some effect on the way the blood pressure drugs are metabolized in the body. But is the setting similar? Is their setting similar to the setting in the study? I mean, is our setting similar? So this is a study done by VIT in Vellore town. So we look at the highlighted thing. So this is the decibel average in the bus stand was 77. This is near Vellore station, which is 80.2, which is high. And this is they looked at a market around Christian Medical College, so probably similar to outside our OPD, 77.4 decibel. The VIT library was 49 and the lecture room was 54. So probably similar to our OPD. It's probably we can extrapolate like that. This is what they looked at the study. So their private office was 37, which is lesser than this. Their public space was 74, which is probably comparable to the outside market. And the earphones which they used actually reduced it to 32 decibel. So probably this setting is similar to our setting. Are there any other outcomes which you would have wanted information, or are there any limitations? There are a few unknown variables in the extremes like white coat hypertension or in a masked hypertension. We do not know if there's variation will be similar. So this is very probably a good tool for screening, where you want to screen a public day and you know the BP is going to be same. But for diagnosis, probably you need to follow the guidelines of multiple blood pressures and take an average of that. So one thing, this probably is a good tool for monitoring when they are on follow-ups. Coming to our case, so based on this study, it's a useful tool for monitoring. So both the BP setting is probably actually correct, and we can use this study as a benchmark for using in our OPD for drug titration. But probably I would be cautious for diagnosing new hypertension in the first visit. Thank you.